There we go.
Hi, how are you? My name is Jason Chandler. I've been asked by the UDA to do an anesthesia review, talk about some of the things that are hot topics in the UDA and the state. Some of the requirements, obviously, that are required for the different anesthesia permits and moving forward with anesthesia CE requirements. So glad to be here doing this recording. I'm here by myself, so this is going to be something new, but glad to be here, glad to be doing this. Anyway, like I said, my name is Jason Chandler. Trying to figure this out here. Okay, there we go. So this is my family. We going through the teenage years. We got a couple of older teenagers. My youngest is 10, but we're trying to enjoy life right now. The kids are kind of easy and they're fun at this point. Not always easy, but we're heavily involved in dance and basketball, and it pretty much occupies our life when not at work. So anyway, that's them. We enjoy each other's time. Anyway, like I said, I am an oral and maxillofacial surgeon in Davis County. We have 4 offices. There's 4 partners, but we take care of anywhere from Davis County all the way up through Weber County, and I've been doing this since 2009. My oldest partner, who is now on mission, he started in 1993, so the practice has been around a long time. That's Dr. Todd Liston. But my other partner, Michael Broadbent, him and I were in residency together at the University of Iowa. I was there from 2005, 2009. That's how we met. And then we brought in Dr. Adam McCormick a few years after me. And then most recently, Dr. Patrick Hall. And so there's 4 of us battling it out in the world of oral and maxillofacial surgery. But as part of the training, we do 4 months of anesthesia training, and that's fully as an anesthesia resident. We're doing cases like ENT, general surgery, orthopedics, pediatrics, cardiothoracic, urology. I mean, you name it, we're doing anesthesia for those cases. So we get tons of airway management, intubations, monitored anesthesia care. So, we get all these experiences in our anesthesia training. And then that sets us up for the residency aspect of our training, where we're doing plenty of outpatient anesthetics. We get thousands of those during our residency. So we get a good experience in terms of anesthesia preparation for the outpatient setting. Anyway, what we wanted to talk about today, some of the objectives. We want to understand the different anesthesia class licenses and updated requirements associated with each one of those. We want to understand the patient evaluation, how we prepare our offices for sedation, and then we'll get into oral sedations and medication involved, and understand some of the pitfalls and office emergencies that we can see. And then, as we kind of finish up some of these things, there are some requirements set forth by DOPL if we have any adverse reactions or emergencies in our office. So the anesthesia permits, the first permit that is available is a Class A permit. This involves local anesthesia administration. This does require a BLS, BCLS, and CPR certification. And your assistant should have equivalent certification for that. It's always better, and I'll probably mention this several times, but it's always better to be over-prepared than under-prepared. And the more you have on your side, on your team, when we have some sort of office or emergency, the more people that are trained and equipped to handle that is going to be better for the patient. And for this Class A permit, there is no anesthesia CE requirement. Class B permit, you're obviously this builds on one another, but you're able to perform all of the duties that a Class A permit is able to perform, plus the administration of nitrous oxide for minimal sedation. And obviously you need to have an accredited ADA program to be certified to administer nitrous oxide, and most dental schools provide that. Once again, must maintain your BLS, BCLS, and or CPR. No anesthesia specific CE requirement for a Class B permit either. Moving on to a Class C permit, everything you can do with A and B, totally fine. You use nitrous oxide plus one enteral drug. Most commonly, this is a benzodiazepine. You must show a completion of training and pharmacological methods of minimal sedation in compliance with the ADA. CPR, BLS, all that needs to be done. You need to have a DEA license to be able to prescribe these medications. And there is a CE requirement of 2 hours every 2 years. Class D permit, once again, building on the other permits that we have, and you must have, so we're talking about getting into IV sedations, you must have a postdoctoral program that has the requirements to perform moderate conscious sedation. And you must have shown and completed 10 sedation cases to receive your Class D permit. Not only do you have to have ALS, BLS, but you have to have ACLS and PALS if you're treating patients under the age of 18. So if you're using this for wisdom teeth, most of those patients, I would say a high percentage of those patients are going to be 18 or younger. And so pediatric advanced life support is required for that. And this for your CE requirements every 2 years, it's 4-hour requirement. Class E permit, this is once again building on the other permits, but you have to complete a postdoc program, meet all the requirements for deep conscious and general anesthesia, deep conscious sedation, general anesthesia. You must complete 30 sedation cases to meet the criteria. And once again, just like the Class D permit, you have to have BLS, ACLS, and PALS. And once again, I mentioned this before, but having your assistants, the more assistants that you have that have these same certifications is going to be recommended. The more people trained, the better off your patient will be, and you'll be prepared for those emergencies when and if they do happen. This requirement is 8 hours of anesthesia specific CE every 2 years. Okay. So once again, talking about those certifications, BLS, ACLS, and PALS, they do not count for CE hours. So even though you're having to do the certifications every other year, and it does take quite a bit of time. I know some of the ACLS programs to renew, I know it's taking me upwards of 8 hours alone to do, going through all the scenarios. They're really good and they're very thorough, but sometimes it is time consuming. Does not count for CE, unfortunately. It's considered unprofessional conduct not to maintain those certifications. So make sure you're doing that. And not a requirement, but UAMS, once again, like we are talking about, if you're doing these sedations in your office, the more people that are certified at your same level, you should have your assistants be trained in those areas as well. And we recognize that that's a challenge, but in a patient first model, highly important that you have as many people on your side and trained as possible. So anytime we talk about doing anesthetics in the office, we have to make sure that we have a good physical evaluation of our patient to make sure that they are appropriate for this type of treatment in our office. Okay, so choosing the appropriate patient for the sedation is the most important first step. Choosing the wrong patient to put to sleep in your office is going to be, it could be a setup for a very big disaster that's not good for everyone, and including the community and your colleagues. So avoiding office emergencies is the ultimate goal, and not always possible, but that is the goal. Patient experience may take a backseat sometimes to their safety. So you hear, and I hear it all the time too, I want to be completely asleep for this procedure, knock me out. I don't want to know anything that's going on, but this is the morbidly obese patient with severe obstructive sleep apnea that is requesting this. So they're not always self-aware, and not always they don't always know what the potential pitfalls and dangers are to their specific situation. Same, and I'm sure you guys have seen this too. My blood pressure is fine. Let's just get this over with. I'm here. And this patient has a blood pressure of 215 over 125, right? It's, they're on the verge of stroke, and they want to, do this procedure. So we are the doctors. We have been trained. We know what the potential outcomes are. And so we have to make what's best in their for their situation, and make the right choice. Informed consent is always an important aspect of treatment. Prior to sedation, you have to obtain their consent, and so this is important, because especially if we're doing oral sedation, right? You have to have informed consent before they have taken these medications, before they're under the influence. And so usually we'll do these types of consents and things at our consultation, as long as we know what the treatment is going to be rendered, so that we don't have to deal with having patients that are under the influence sign consent forms, which is not advisable. Also make sure that in terms of documentation that you're mentioning some of the risks in a separate clinical note than your actual consent form, so that they can be admissible in the court of law if needed. Peri-antibiotic therapy, oral antibiotics, or antimicrobial mouth rinses. We need to determine who needs those medications, who doesn't need those medications. This is at the discretion of the provider. Some patients may have a medical history that indicates the use of antibiotics preoperatively. And so, we need to determine who is and who isn't at risk for that. Include an ASA classification in your note. Obviously, in terms of the patient having a safe anesthetic in your office, ASA class 1 and 2 are probably going to be where you want to stick with. Anything more than that, make sure you're set up and you're prepared for worst case scenario. But perioperative fasting is important. Best to have the patients fast for 8 hours if you're doing sedation. And there are specific instructions to follow: clear fluids, light meals, greasy foods, et cetera, et cetera. But the more information that you give them, sometimes they get confused. I find it in my practice, I just tell them 8 hours. I'm not telling them you can do clear fluids up until 2 hours, which you can do, but I don't know, it just kind of complements, it muddies the waters. And so we just try to keep it simple and say, nothing to eat or drink for 8 hours before. For oral sedation, same, have them fast for 8 hours, but take the oral sedative 1 hour prior to the appointment with 8 ounces of water. Food in the stomach can decrease gastric emptying time and delay your peak onset, or even your initial onset of your medication that you're trying to use. So 8 ounces of water. Discharge criteria: sedated patients must meet an appropriate discharge status that will permit them to have a safe recovery. And there is an Aldrich system, a modified Aldrich system, post-anesthesia discharge scoring system. And so each one of these systems has different criteria that you give them a score for, and they have to meet a certain number before they're able to be discharged from their office. So, going through this whole system is important so that and you feel confident that they're going to be discharged and recover safely at home when you're not there to provide assistance if there's an emergency. History and physicals. I know we've been through a lot of this with our training, but it has to have each one of these criteria. Chief complaint, which is in their own words, history of present illness, past medical history. Go through these things, be thorough, have a complete medical, dental, psychological conditions or illness, your hospitalizations, anesthesia experiences. This is especially important if we're talking about potential for malignant hyperthermia and a family history. So surgical dental history, we want to know, have they had surgery before, especially if they've had oral surgery or gone through a sedation before. How did they react? Was it smooth? A lot of people will have certain allergies that they've encountered through these procedures, and so it's important to note all of those things. Obviously, their medications and doses and how that will affect your sedation, allergies and reactions. You want to have a good review of systems. You go through your physical exam, your general overall health or physical appearance, head and neck exam, cardiovascular exam. You want to make sure that you go through their whole history. Have they had a myocardial infarction or bypass surgeries? Any issues with their lungs, asthma, COPD, those things are always extremely important. They should be at the top of your list in terms of your review systems. GI tract, musculoskeletal, your integumentary system, neurologic, psychiatric, and endocrine systems. Your hematologic, lymphatic systems, your immunologic system. All of those things, if they have something outstanding in those, you want to touch on them, ask follow-up questions, just so you have a better idea of their overall health. Have a good family history, social history, their history of substance abuse, post-traumatic stress disorder is something that you want to know about. Is something going to all of a sudden appear as you sedate the patient and their inhibitions are gone? Is something going to surface? Especially violence. So you want to make sure that you have a grasp on that. Physical exam, once again, go through these areas, note anything abnormal. Make sure that you have a good idea. I put on here, likely you're going to, defer any breast exam or pelvic or rectal exam. Those things aren't really applicable to our procedure, so I wouldn't stress too much about that. Any adjunctive studies that we may have, if we have cone beams in our offices, obviously our X-rays are going to be under this area. But if we've had patients that have a big history of myocardial infarction and a cardiovascular history, that we're going to have to reach out to their physician to get a better grasp on where they're at. That should be noted in here that we've recommended further evaluation by EKG or if they have a need for chest X-ray or whatever, that should be noted in those areas. Labs as well, you're probably going to be, if you have a patient that needs labs, it's probably going to have an additional consultation with their physician to help. Radiographic exams, we do this all the time, right? But we need to make sure we have the appropriate radiographs. I know in my office, we get a lot of referral radiographs. We need to make sure that the radiograph is up to date. Make sure our radiographs are appropriate for the procedure that we're going to do. Assessment, make sure we have an appropriate diagnosis for the treatment being rendered, plan, and make sure we have a detailed plan laid out for our anesthesia as well, with language about the consent for the procedure being discussed. So once again, office preparation for anesthesia is going to be extremely important. Emergencies happen, so we all need to be prepared for that worst case scenario. Having these permits, we have to have ACLS, we have to have PALS, we have to have BLS. So if the whole team is prepared and ready and has training for these types of scenarios, we're going to feel better prepared going into these procedures. Once again, airway management, and even if you're doing, I would say even if you're doing a class A, I mean, people pass out, people have seizures, if you have a decent grasp on BLS and you can have decent airway management until the paramedics come, the more prepared you are, the better. ACLS is always a good idea. You can be more prepared, even if you're having, you don't have a requirement for ACLS. It's a good arrow to have in your quiver. Have the proper equipment. You want to have blood pressure, cuff, electrocardiograph, especially if you're doing IV sedations, you need to have EKG reading. Defibrillator, everyone should have an AED in their office. Pulse oximetry, capnography, if you're doing IV sedations in your office, we feel like it's a standard of care to be monitoring their end tidal CO2. So make sure you have a capnography equipment. Operating room, how is your operating room? Is there enough space? Can 3 people move around the patient freely? If you end up calling the paramedics to come and help, is there enough room in the operating room that the emergency personnel can come in and do what they need to do to treat the patient? What's your chair like? Patient needs to be positioned so that the team can maintain airway. Can their position be altered quickly in an emergency? Is there a firm back? So if you end up needing to do CPR, do you have the appropriate chair to be able to perform adequate chest compressions? These things need to be evaluated in your working space. What's the lighting like? Obviously, you want to make sure that you can see for what you're doing, and we're used to working in dark spaces, but the overall light, you want to be able to maintain the patient's skin color. Their oxygenation is important to be able to evaluate how they're doing, and the patient's skin color. Do you have backups for those? If the lighting goes down, what's your backup plan? Okay. Same with suction. A lot of times we have powered suction. So do we have sufficient to aspirate the oral cavity? And especially, do we have a backup if power goes down? Oxygen delivery system, a lot of times we have it plumbed into our office, but we need to be able to perform positive pressure ventilation as well. So do we have a tank, an emergency tank, a bag valve mask, an ambu bag? Is there enough oxygen in our backup as well? And make sure you check that every day. That should be on a checkoff list, that oxygen is our best drug to give to these patients. And so make sure you have enough, adequate for your normal procedures and backup. How's the recovery area? Once again, you have to have available oxygen during the recovery. suction, lighting, everything that you have in your operating room. If an emergency happens in recovery, you have to have all these things readily available, outlets, and you have to have adequate visibility for your team member to, you don't want to stick a person in recovery and forget about them. So make sure that someone can be observe your patient at all times there. Some ancillary equipment to have, and especially some of these things, specifically for IV sedation, but you want to have a laryngoscope, a variety of blades, batteries, backup batteries, light bulbs. You want to be prepared, even though it's not something that you're having to pull out all the time. But make sure you check those. Once again, this is on the checkoff list. Have all those things ready every day. Cricothyroidotomy kit, endotracheal tubes with the appropriate connectors. Okay, so that's important. I know, in my office we've been through this. You don't always go through the whole scenario, and so put the endotracheal tube in. Do you have the appropriate connector from your oxygen delivery system to the tube? It sounds like it's a no-brainer, but sometimes the way people are ordering things, you don't always have the same connectors, and so you want to make sure that everything is seamless from start to finish. You have all those appropriate the equipment. Oral airways, supraglottic airways, so laryngeal mask airways. Yank-hour suctions. You want to make sure that you're able to clean any fluids that go down the patient's oropharynx. And of course, McGill forceps to help with intubation or foreign body removal if that does happen in the subglottic area. Blood pressure cuff, stethoscope. We mentioned that, AED as well. Some of the drugs that is important to have on hand. Some of these are IV, some of these are not, but vasopressors. You want to make sure that you're able to increase the patient's blood pressure if needed. Steroids, bronchodilators, and these bronchodilators are going to be important. I would say, albuterol if a patient is asthmatic. If you're doing anything that involves sedation, if a patient has an asthma attack, and this is one of those things going back to our patient evaluation. If you've asked the appropriate questions, how often they're having asthma attacks, are they severe asthmatic? Are they having asthma attacks every day? And if so, make sure they're on top of it. Usually those patients are, have their rescue inhalers and they're on long-term, steroid for that. But make sure that we're prepared for, an asthma attack in our office. Muscle relaxant drugs in case you need to intubate. Cardiac meds in case of an arrest. I would say, if you have an EpiPen in your office, it's probably not going to be, if you're not doing IV anesthetics, having an EpiPen in your office for allergic reactions is probably not going to be sufficient. If a patient goes into cardiac arrest because they need more dose for that, but it's not a bad thing to have some medications to help with cardiac support. Narcotic antagonist, Narcan, and benzodiazepine antagonist, flumazenil. You want to have some antihistamines in case of allergic reaction, Benadryl, antiarrhythmic, anticholinergics, coronary vasodilator. So this is something that every dental office should have anyway. Nitroglycerin in case you go through the MONA acronym. If someone's having a cardiac event, you want to be prepared. Antihypertensives, we use those fairly frequently. We have a lot of patients with hypertension in our community, in our offices, and so it's something that we go to frequently. Dantrolene for malignant hyperthermia, it's kind of a cumbersome process, and knock on wood, it's not something that we have to do very often. And there is a malignant hyperthermia hotline, but if you recognize and know that someone's going through this malignant hyperthermia, dantrolene, important to have on hand. Crash cart. Everyone, I feel like any dental office should have a crash cart. You know, a specific area with everything in organized that you know, it minimizes the you know, thrashing around and looking in, you know, when an emergency happens, because we all know when an emergency happens, it's not time to sit and think through things, right? I mean, you really need to be able to think through things. It's just, you know, does it happen? It's hard because you're you know, fumbling for things. You're trying to, you know, get things done quickly, and so the more organization your crash cart has, the better. So you can minimize the looking for things. So organize it. We have airway, your cardiovascular meds, your AED, your back valve mask, other meds. You know, for patients with diabetes, you have glucose, allergic reactions, Benadryl. This is our crash cart in our office. It's just a tool cart, but you can see on the top of the cart here, you know, we have, this is the intraosseous IV kit that we can use. If we can't get IV access, we can get into the tibial plateau. Our AED, which is checked every day. The CPR board, so this is when I mentioned your chair and how firm the back is. I think our chairs are pretty firm, but you know, we have the CPR board that we can put underneath their thorax. You know, as we're doing chest compressions, we have a firm background, so we can give adequate and appropriate chest compressions if needed. And then once again, we have this is our back valve mask with backup oxygen on the floor, and then, like I said, our tool cart. We'll go through that. I know this doesn't look very organized. It kind of looks jumbled in there, but you know, we have all of our ACLS references in here. So you know, if once again, we're trying to minimize having to think through this, so we have it all. You know, all organized. If we're having a cardiovascular event, you know, flip to the cardiovascular event. You know, we'll go through. It's hard to try to remember all those things when you have something going on in the office. And so, you know, go through the steps. Make sure you have those reference points. You have some backup extra stuff. You know, some connections and things in here. Next drawer down, more IV supplies, some gloves, some sterile gloves, syringes. We have some IV bags, yank hour suction tubing, other backup pulse oximeter. We have equipment fails, and so you know, the more backup you can have, the better. This is our emergency drug. So once again, this is where organization comes into play. Trying to minimize thinking, and so all these medications, all the red ones, are cardiovascular drugs, and it's already on the tag. You know, the dosage that is required for the treatment, and on the back of the tag, there's if it needs to be diluted or specific instructions on how to pull it up. So have your drugs organized, put tags on them, color code them, whatever you need to do to try to minimize having to think during I'm not saying you don't have to think, but you know, trying to minimize those things that you don't have to remember is going to be better for you and better for the patient. Next order down, once again, you can see we have a lot of backup. We have more ambu bags. We have 2 of them. We have more circuits, more masks, more connections, just in case. And down here, you can't really see this, but this is also rudimentary suction. So it's just it's like a bulb suction. So if all power goes down, we have a backup electric suction that we can plug into the wall and use if needed. But if all power goes out, then that's worst case scenario. We have a bulb suction that we can use to to suction out debris and saliva or whatever it is. This airway box that we have, this is in, so the crash cart that we have stays in the hall and we can wheel that into the room if needed. It's not something that we use. Hopefully we don't ever have to use it, but this airway box, this is something that's in the room anytime we're doing an anesthetic. Okay, so airway is extremely important. So we want to make sure that if we lose an airway, we have it at our side, ready to go. So in our airway box, we have our laryngoscope with different blades on here. These are Mac blades, so different sizes for different size patients. These are Miller blades. We have our McGill forceps over here, trauma shears in case we need to cut off clothing for CPR. We have backup batteries. We have backup light bulbs. We have an albuterol inhaler here. We have lubrication for our endotracheal tubes and our laryngeal mask airways. We have one tracheal tube that's already set up with stylet in there. So if we need that, it's ready to go. We have, this is Afrin nasal spray. So in case, this is mainly not for an emergency, but if we're doing an intubation, the nasal intubation, that can help reduce bleeding. We have some oral airways here, some nasal pharyngeal airways here, and then this is our cricothyroidotomy kit. And it's pretty simple, it just has a sharp tip on this, on a syringe that we put through the cricothyroid membrane. We can aspirate to make sure that we're getting air that are in the trachea, and then we have connections from, this is our connector tube. It goes on top of this connection here, and then that will go to our oxygen delivery system. Moving into oral sedation, there are some advantages to doing oral sedation, and it's a very common thing, and especially in today's society where they feel like it's more and more common to ask for it. There are some advantages, but we need to also know that there are some disadvantages to oral sedation, absorption and bioavailability. The rationale for use is there, and we're going to cover some of the drugs that we use. And there's different categories: sedative, hypnotics, anti-anxiety drugs, histamine blockers, and opioids. The advantages of oral sedation, universal acceptance. Most people are okay taking a pill. I would say most people, there are some outliers there, but it's usually not too big of a deal to take medication. Pretty easy to administer, cost is low, and there's low incidence of adverse reactions, to be honest with you. There's decreased severity in adverse reactions as well. No needles. Once again, this is going back to the universal acceptance, is that you're not having to deal with needles. And there's really not, in terms of specialized training, there's not, it's not extensive. So, but the caveat to that is you do need to understand risks and complications and how to manage them, especially airway management. So yeah, some of the disadvantages of oral sedation: patient compliance. They could take too much or too little in a culture where if one is good, two is better. We see that a lot, but we also see the reverse of that is people are afraid of taking too much, and so they end up not taking enough, and they don't see any benefit there. It could be, you could have a prolonged latent period, so it takes about 30 minutes to kick in on most drugs that we're going to use, and an hour to hit their peak effect. So there is that window of time that it takes to work, and you can't always 100% predict how the drug is going to be absorbed in the GI tract. Gastric emptying can play a part in that. Food, high anxiety levels can affect it as well. It can delay gastric emptying, and so all these things you really can't control. it's just, take a pill and let's see how it goes, right? The disadvantage also, you can't really titrate the drugs. You can't give more, you can't give less, based on how the patient has responded. And there's prolonged duration of action. So, it's not like a light switch anesthesia where you can turn it on, turn it off. Absorption, talking about that, there are lipid soluble drugs that absorb quicker than non-lipid soluble drugs. The pH of the drug also determines the solubility. And so aspirin is a very acidic drug. It absorbs quickly, okay? The stomach pH is about 1.4. The small intestine is about 4 to 6. And so once it exits the stomach into the duodenum, that's where most of the absorption is happening. And gastric emptying, so we mentioned that briefly in the last slide, that can delay the drugs from getting to the small intestine. If most of the absorption is happening in the duodenum, well, we got to get that drug from the stomach into the small intestine as fast as possible, right? Well, there are some things that can delay that process from happening. And so that's why we mentioned early on in the lecture that 8 ounces of water is going to be recommended for taking these medications. But fear, anxiety, which is ironic, right? Because that's why we're giving these medications. A lot of these patients, are deathly afraid. And I see this in my practice as well. We see a young teenager that is deathly afraid of needles and, deathly afraid of coming in to have their wisdom teeth out. I totally get that. But they want, some Valium before they come in or some medication to help calm them down. Most of the time, those drugs aren't helping because that fear and anxiety is kind of overcoming it. These medications aren't strong enough to overcome that fear and anxiety. And so, and it can delay the gastric emptying. So, it is one of those things that, may affect your treatment plan for oral sedation. And liquids get absorbed quicker than tablets. Drugs are formed from different particle sizes, and they're absorbed different rates, even given in the same dose. And so, you have 2 medications, same dose, they may be absorbed at different rates. So the problem is, we see a patient, we've given them medication, they come and they have no effect, right? Do you give them more? That's the situation where we're in. You give them more. Unfortunately, it takes a long time to set in. It takes at least a half hour or an hour to get your peak effect. And then by the time it hits the peak effect, was it a gastric emptying problem? And now they're more sedated than you actually thought that they would be. And so there's, like I said, the titration of these medications is very difficult to predict. And so that is a downside of dealing with these medications. But most duration of the drugs that we use in the dental setting is about 3 to 4 hours. And that's typically too long for most procedures. So you need to plan for someone to take care of these patients afterwards so that they can recover safely. And many people do have dental phobias and anxiety. It's something that I think all of us deal with on a daily basis. These medications that are available are great for lighter levels of sedation. It'll help take the edge off. But for severe, deeper, severe levels of anxiety or deeper levels of sedation, it's not going to be ideal. Okay. So like I said, it may help alleviate some anxiety leading up to the procedure. So you may have patients that are losing sleep because they're worried about this procedure for the week that comes. That may help, if you decide to give them a sleeping aid or some of these medications to help them, be more relaxed getting up to the procedure. That's an option as well. And once again, it's a great option if IV sedation isn't possible. So in terms of the drugs, specific drugs and pharmacology that is available, sedative hypnotics, in that class, we have barbiturates, benzodiazepines, and non-benzodiazepines. There are some anti-anxiety drugs. We'll go into that. There's some overlap there. Histamine blockers and opioids. All of these can cause oral sedation, are used in the dental setting. So under sedative hypnotics, alcohol is one. You may have patients that pre-medicate, pre-medicate unbeknownst to you, but they take it upon themselves, and this is something that can help lighten them up. It is under that category of sedative hypnotic. Barbiturates, the pharmacology of this is it is a CNS depressant. It works on the ascending reticular system, which is important in the maintenance of wakefulness and sleep. Secobarbital, the duration of action of secobarbital is about 3 to 4 hours. The downside to these medications is there's a hangover effect. So you get irritability, drowsiness, and impaired judgments for several hours after the dose. They don't obtund pain, so and most of us don't really have too much of an issue with that because we're also giving local anesthetics, but you need to make sure that your local anesthetic is profound because these patients aren't getting any pain relief from the medication. And there's respiratory depression. So they're lighter sedation. You're probably not going to have a whole lot of effect on the breathing, but higher doses, the higher you get, you're going to have a notable respiratory depression. Your effects on cardiovascular system, once again, lighter doses, not going to have as much effect as heavier doses. You're on your heart rate and blood pressure. Your liver, so it's very similar to alcohol falls under this, and we all know the sequela that can happen from alcohol usage, but patients who are hypersensitive to barbiturates can see liver damage, and patients who have known liver damage are probably bad candidates for barbiturates. Tolerance can be an issue. So usually not an issue if because you're not giving this all the time, on a daily basis. You're not having someone come into your office on a daily basis, but there is a tolerance that's built up on these medications, and you may see someone who is taking this for a certain medical condition, right? They're going to have a tolerance that's going to be built up over time, and it doesn't take too long, 2 weeks. Dependence also. So, you have these issues with potential addiction over a prolonged period of time. Once again, not as much of an issue in a dental setting where we're seeing these patients on an infrequent basis. There are long-acting barbiturates. Phenobarbital is one, and so once again, this is going back to building up a tolerance and dependence. Some people are on phenobarbital for anti-compulsive therapy. It's longer lasting medication. Intermediate acting, you have amobarbital, butabarbital. Those are sleeping pills. Short acting, pentobarbital. And these are 3 to 4 hours, so better suited for our dental situations. Secobarbital, methohexital or Brevitol is something that was used in the oral surgery setting in an IV form. It was. I hear the good old days is more like rodeo anesthesia, because the patients weren't as sedated as we see with some of the newer drugs that we have today available to us, like propofol. Contraindications to barbiturates. This is going to be very similar throughout all of these medications that we're going to talk about, but allergy, that we just assume that if there's an allergy to these medications, that it's a contraindication. Uncontrolled pain. So once again, these medications don't help control pain. If they have addiction to sedative hypnotics, not a good idea. If they're on anticoagulants. Once again, this affects the liver, and so if they're on anticoagulants, that could get you into a bleeding situation. Digoxin, if they're taking that for CHF or other heart-related issues, then you're going to want to stay away from barbiturates. Also, porphyria or acute intermittent porphyria, barbiturates increase the synthesis of porphyrins, and so this could precipitate, leading to a nerve demyelination and paralysis and even death. And so, once again, you're going to find that out in your H&P, prior to even seeing these patients if they have a history of porphyria. Pregnancy and lactation, so it does cross the placental barrier found in breast milk, so you want to stay away from that. Causes CNS depression in the fetus and the baby. So drug-drug interactions, it decreases the potency of coumarin anticoagulants, and so once again, this is also something that you have a plan. If you're planning on using barbiturates and you have someone that's on anticoagulant, you have a conversation with their physician, let them know what your plan is, talk about it. And this is probably going to be something that's brought up in, if you tell them you're planning on using a barbiturate as an oral sedation, hopefully this is communication that you have that that's going to decrease the efficacy of their anticoagulant. Which may not be a bad thing. They may be okay with that, but that's a discussion that you need to have. Your steroid deficiency is going to be decreased. Your CNS depressants, if you're on multiple CNS depressants, that could be a bad airway, compromise if they're adding on one another. So pentobarbital, once again, it's a short acting. It's scheduled to, your onset of action is not too bad, 15 to 30 minutes, but it has a 3 to 6 hour duration. It is the preferred barbiturate for dental sedations. Okay, it's available in 50 and 100 milligram tablets, and the average dose is 100 milligrams 1 hour prior to the dental appointment. Secobarbital, also short acting, same as the pentobarbital. This therapeutic index is lower than pentobarbital, so this means that the level of drug required for an effect is closer to the amount that causes death. So you have a higher likelihood of unwanted side effects with secobarbital. It's also available in 50 and 100 milligram tablets, and the dose of this is 100 to 200 milligrams 1 hour prior to the appointment. So, in summary, using short-acting barbiturates, you have this potential for over-sedation and some side effects. There are other forms of oral sedation that have proven to be better, and so I would probably lean towards some other drugs or categories that we'll talk about. But if you've gone through all those and they haven't worked, this may be something you fall back on. Benzodiazepines. So leading into that, that's probably the most common drug used for, or drug category used for oral sedations. You have florazepam, temazepam, triazolam, lorazepam, midazolam. You also have some non-benzodiazepine sedative hypnotics, zolpidem, Zalopon, Zaleplon, and chloral derivatives like chlorohydrate. So the benzodiazepines, they are anti-anxiolytics. They target the spinal cord and brain, interfering with glycine and GABA reuptake. You have a decreased occurrence of this hangover effect, like we talked about in the barbiturates, and you have minimal effect on the hepatic microsomal enzyme system. So overall, you have less risk than your barbiturate group of medications. Florazepam or Dalmane comes in 15 and 30 milligram tablets. It is Schedule 4. Your onset of action is about 30 to 60 minutes. It's metabolized in the liver. So you have some caution with patients that have liver issues or dysfunctions, contraindications, once again, allergy and pregnancy. These warnings are pretty typical with any sort of sedation. I would say, you don't want to operate heavy machinery, drive. You don't want to combine it with other CNS depressants. The dose of the florazepam is 30 milligrams taken 1 hour prior to the appointment. Or if you need to make some dosing adjustments for the debilitated or elderly, I would use half, so 15 milligrams. Temazepam or Restoril comes in 15 and 30 milligram tablets. It's a Schedule 4. The onset is 20 to 30 minutes, peak effect 2 to 3 hours. So you got to think about some of these things, right? How long is your procedure going to take? How long do you need it to, most of these medications take, 20 to 30 minutes to kick in. But, when do you have them take it prior to your appointment? So, that may play effect in what you prescribe. But it's yet best used to keep patients asleep at night, but not get them to sleep. So it has this slow peak effect, helps keep them asleep, but not, it's not very fast. So it's not going to get them to sleep very quickly. Same contraindications and warnings as florazepam. Your dose is 30 milligrams 1 hour prior to bedtime, or 15 milligrams in those patients that are elderly or debilitated. So triazolam, probably one of the most common or the most common drug used for oral sedations. Halcyon comes in 0.125 and 0.25 milligram tablets. Once again, Schedule 4, short half-life. So 1.5 to 5.5 hours. Peak effect is about just over an hour after the administration. And once again, most common drug. Contraindication, same as the others. Same warnings as the others as well. It can cause some anterograde amnesia and some paradoxical reactions. So you may end up getting patients that are not sedate, right? They're kind of thrashing around and moving all around. These paradoxical reactions happen from time to time. We see that through the administration of midazolam in the IV. And so we're usually giving a cocktail of medications, and so we're able to kind of overcome some of these paradoxical reactions. But if you're only giving triazolam, you may see that you're not getting the desired effect. And so if that's the case, you may have to make a game plan the next time you have them come back and use a different medication. Don't want to add any CNS depressants to these, including narcotics. The dose of the triazolam is 0.25 milligrams 1 hour prior to bedtime or dental appointment, or half of that in elderly or sensitive patients, or double that may be necessary in patients who don't respond to the lower dose. Lorazepam or Ativan. This is something that we use more commonly in the hospital because it does come in an IV form, but it comes in 0.5 milligram, 1 milligram, and 2 milligram tablets. You do have a slower absorption rate with peak levels that are about 2 hours. So once again, I mentioned this, we use this on the hospital floor because it can be given IV as well. And so you have patients that have a lot of our jaw fracture patients that we wire their teeth together. They get very claustrophobic. They have kind of some anxiety towards it, and so we end up giving them some anti-anxiety medications like Ativan to help with that. Same contraindications, same warnings as the others, but in lorazepam, you also want to watch out for patients that have narrow angle glaucoma, as it can increase intraocular pressure. Not recommended for patients with psychosis or primary depressive disorder. The dose of this is 1 to 2 milligrams per dose every 8 hours for anxiety, and 2 to 4 milligrams given 1 hour prior to sleep or dental appointment if you're giving it for your dental appointment. Midazolam, Versed, does have quick onset. about 30 minutes post-administration, most commonly used for pediatric patients less than 6 years old who can't swallow tablets, because this does come in a syrup form. Contraindications, we've mentioned some of these, same as the other benzos, but narrow angle glaucoma as well, severe COPD, congestive heart failure, and impaired renal function. I would say, some of these people are moving into like an ASA 3 or 4 situation. You're probably not going to want to treatment plan them for office sedation anyway, in terms of your normal dental setting. Your dose of midazolam is 0.25 to 0.5 milligrams per kilogram with a maximum of 20 milligrams per dose. So you have oral sedation, these non-benzodiazepine anxiolytics or hypnotics. We mentioned that we're going to talk about these sleep aids. The zolpidem or the Ambien comes in 5 to 10 milligram tablets. It's used for insomnia. It works on the GABA receptor complex. Its onset of action is about 45 minutes. It hits its peak action around an hour and a half, and it's safe to use in pregnancy. So the precaution for this, if patients have a compromised respiratory system, you see some respiratory depression in zolpidem. So if they have obstructive sleep apnea, probably not great to add a sleep aid to someone who is going through some respiratory issues while they're sleeping. Contraindication, allergy, of course. You also, we mentioned the porphyria with the barbiturates. We're going to talk about that again. You want to use some precautions here as well with acute intermittent porphyria, impaired renal or hepatic function, and an addiction-prone patient. May not be a great candidate for someone to use Ambien. Adverse effects. They could be some of the desired effects, in terms of drowsiness, but you could have some dizziness, headaches, back pain, lethargy, nausea, dyspepsia, diarrhea, myalgia, arthralgia, xerostomia. So just have a good grasp on these adverse effects when someone calls and they said that they're having some nausea afterwards, or diarrhea, or is this normal? You can say, yeah, there are known side effects for these medications. The dose of this is 10 milligrams given before bed. Chloral hydrate is in these medications we're going to talk about, although probably more old school. But once again, we talk about having armamentarium for different patients, and some patients may have these undesired effects or side effects on midazolam. It may be that we've exhausted some of those medications, and now we're left with chloral hydrate. And so this comes in 500 milligrams per 5 ml syrup, or 500 per 5 elixir. Most commonly used in the pediatric population. Is similar to oral Versed. Is dispensed as a syrup, and great for kids that can't swallow pills. The taste is gross, so it usually has to combine it with something else, juice or ginger ale, so that the patient can tolerate it. And GI disturbance is commonly reported in these patients. So just be aware of that. Some contraindications: severe hepatic or renal disease, cardiovascular disease, gastritis. Once again, these are some of the things, if people have some of these issues, may not be a great candidate for oral sedation in your office anyway. Nursing mothers. Warning, it can be addictive, and I don't think that's as much of an issue in a dental setting. You're not giving it often enough to become addictive, but just have that on your radar. We see this again, the drug interactions that can affect coumarin anticoagulants, so the PT can be affected. If you have a patient that's anticoagulated, have the discussion with their physician, let them know what your plan is, and then you can work out some sort of plan, or even an alternative if it's going to be an issue with their anticoagulation. CNS depressants, all these medications, don't add CNS depressants on top of CNS depressants. You'll avoid catastrophes if you do that. Adverse reactions. So we mentioned this. You have gastric irritability is reported the most common with it. So chase it with milk. 8 ounces of water to reduce that effect. The dose of this is 500 to 1500 milligrams taken 15 to 30 minutes prior to the appointment. And if you're taking the cerebral elixir, mix it with half a glass of water and ginger ale or fruit juice. And once again, you probably want to chase it with some milk or water, to reduce the gastric irritability. Anti-anxiety drugs. Here's some of this crossover here with benzodiazepine. We have chlorodiazepine epoxide, diazepam, oxazepam, clorazepate, prazepam, halazepam, and alprazolam. These are all anti-anxiety medications in the benzodiazepine category that you'll get to help with some of the oral sedation as well. But they're most commonly used medications to treat mild to moderate anxiety. Diazepam and oxazepam are ideal for the dental setting. They're listed as drugs. They have different onset and peak actions, so your patient may benefit from one or the other drug. So depending on whatever situation you're looking for, one drug may be better than others. So you want to make sure you're limiting these prescriptions to patients that aren't family or have close relationships. You don't want to be flagged by the DEA and DOPL for inappropriate prescribing methods. Diazepam, you have 2, 5, and 10 milligram tablets. This is Schedule 4. You have the rapid onset, 90% peak plasma level is about at 1 hour, and used for mild to moderate anxiety. We use diazepam for, and I usually try to stay away from using diazepam if I'm being honest. For patients that are coming in and they're afraid of an IV start, I usually try to recommend doing nitrous oxide to help with that, just because I can titrate the nitrous oxide, I can get it out of their system and use the IV medications after that. But these patients that have high, we mentioned this before, patients that have high anxiety level to begin with, they take the diazepam. We don't usually see, they still freak out when we give them the IV. And so does it work? Does it not work? Is it this gastric delaying, emptying that's been delayed and that's why it's not working? Whatever it is, if they have high anxiety levels, they may not see a huge effect with diazepam. And the dose of that is 5 to 10 milligrams 1 hour prior to the appointment. Oxazepam or Cerax comes in 10, 15, 30 milligram capsules. It has a short elimination half-life, so about 6 to 11 hours basically. Great for dentistry or surgery as it doesn't stick around for long, as long as the other drugs. Peak plasma levels are between 1 to 4 hours. The dose of the Cerax is 10 to 15 milligrams, three times a day or 4 times a day, and 10 milligrams for 3 times a day for elderly patients. So this may be something that you use, leading up to your dental procedure, if they have high anxiety level or moderate anxiety level leading up to the procedure, to help them get some sleep or help them just kind of relax. It's not indicated for children less than 6 years old. Xanax, you have patients that probably prescribe this from their general physician. We see patients on Xanax for just normal anxiety control, but that comes in 0.25, 0.5, 1, 2 milligram tablets. Peak plasma levels are 1 to 2 hours, and the dose is 0.25 to 0.5 milligrams 3 times a day, or on the lower end for elderly patients. These antihistamine blockers, they have some hypnosis and sedation side effects. So the drugs are used primarily for allergies and motion sickness and Parkinsonism. But they noticed a lot of these medications, they had these kind of a sedative effect as well, and so you can use those for as an adjunct drug if other medications aren't working. But some of these medications, like I said, combined with scopolamine for drowsiness or nausea. Probably the most common one here, Benadryl can cause some drowsiness. You can try it. Phenergan as well. Phenergan is an antiemetic. This comes in oral form, comes in suppository if you need to, if they can't swallow pills. And this was commonly used with Demerol in the past for sedation, and hydroxyzine as well, or Vistaril. So Phenergan is something that we use fairly frequently in our office as well, mainly for nausea, but this comes in 12.5, 25, and 50 milligram tablets. Classified as an antipsychotic or a major tranquilizer, and it's used to decrease agitation, hostility, and combativeness, and hyperactivity. Also used to treat nausea and vomiting, which is what we use it for. We have to use extreme caution when we use it in the IV form. We have to dilute it, and it's usually recommended given in a large bore IV in a large vein, because these are some of the issues that you can see. This is Phenergan infiltrated in a small vein in the hand. You can see this is a really bad day for the patient, really bad day for you. You get some of this necrosis. This is not good. So use extreme caution when using Phenergan IV in your office. More antihistamines. Well, I guess the Phenergan continued allergies, contraindication, don't combine with other CNS depressants. Fairly standard stuff there. No heavy machinery. It does lower the seizure threshold. So in patients that have convulsive disorders, need to make sure that they understand that that is a possibility, and make sure they're staying up on top of their seizure medications and watch for those. Children with acute disease like chickenpox, measles, gastroenteritis, more susceptible to extrapyramidal effects. Once again, these adverse reactions, you get xerostomia, blurred vision, dizziness, oversedation, extrapyramidal effects. So like restless leg, motor restlessness. You can get acute dystonias, so perioral spasms, Parkinsonism, tremors, rigidity, postural abnormalities, mask-like face, hypersalivation, tardive dyskinesia. And so the treatment of these extrapyramidal effects, we discontinue the drug and administer Benadryl, 25 to 50 milligrams. So the dose for Phenergan is 25 to 50 milligrams 1 hour prior to the appointment, or 50 milligrams prior to bedtime. You can adjust the dose lower, like the 25 milligrams, or even 12.5 milligrams is something that we'll use once in a while in children and elderly. Hydroxyzine comes in 10, 25, 50, and 100 milligram tablets. It also comes in a syrup. And so, and Vistaril comes in an oral suspension. So this is a group of drugs called diphenylethanes, or H1 blockers, and it's most commonly used in peds dentistry. So, and 50% of the responding pedodontists reported using one or both drugs. The onset of this is about 15 to 30 minutes. Peak effect is about 2 hours with a duration of about 3 to 4. And the liquid form of Atarax is more pleasant than the Vistaril, as an FYI. The hydroxyzine dose is 25 milligrams 3 times a day, up to 100 milligrams 4 times a day. If you have kids less than 6 years old, you take 2 milligrams per kilogram, divided into the doses, every 6 to 8 hours. And then kids 6 to 12 is 12.5 to 25 milligrams, QID to TID. And perioperative adult dose is 50 to 100 milligrams 1 hour prior to the procedure. Preoperative dose for peds is 1.1 to 2.2 milligrams per kilogram. Moving on to inhaled anesthetics, the nitrous oxide. It's been around for a really long time. 1844. 70% of the dentists doing sedation in their offices use nitrous oxide. The advantages to the nitrous oxide is it has a short latent period, so it takes 15 to 30 seconds to hit its onset of action, and it has the ability to titrate. So you turn it up, turn it down, rapid reversal, you turn it off and let them breathe the oxygen. They usually come out of it pretty quick. And they can drive home after. So it's a great adjunct to what we do. And like I said, this is probably my preferred choice on someone who has anxiety. For the IV is, we get them on some laughing gas for 5 minutes or so, and it usually gives them enough courage to get the IV. The disadvantages is it's not very potent. So when given with 20% oxygen, which should always be delivered, there's a certain number of people that won't even feel the effects. Okay, and it does require patient cooperation. The patient has to sit still. They have to breathe through their nose, and sometimes when they're they're kind of in the zone, have high anxiety, they may not even listen to what you're saying. So that's part of it. They have to cooperate, and you have size and cost of the equipment. It takes some additional training and knowledge and all aspects of the clinical administration. And it doesn't consistently control pain. So that's part of it too. You have to have good local anesthetic. So I wanted to touch base on a few anesthesia related emergencies as well. For all emergencies that happen, you want to stop the procedure. Continue to monitor vitals, consider dialing 911 early. So you have a good feel about what this emergency, if it is emergency, is it something you feel like you have good control of or not? Have a good grasp on that early. And that's why I say, having people around you that are trained, that know how to recognize an emergency, sometimes they can see from an outside perspective and give you some advice on dialing 911. But you can use this algorithm to help handle all complications in an organized manner. But P, A, B, C, D, position the patient. I don't know why we have P first, but position the patient. And then airway, breathing, circulation, and then definitive treatment, including differential diagnosis, drugs, and defibrillation. Respiratory, so things that can happen in a respiratory situation. Laryngospasm, if you have a patient deep enough with an oral sedative and nitrous oxide, that their ability to protect their airway is gone or diminished, then you could have a laryngospasm where the vocal cords slam shut. And so you want to be able to break that. And typically it's 100% oxygen given through positive pressure. So you want to have a back valve mask that you can deliver the oxygen with pressure, and hopefully be able to break that laryngospasm. So you want to suction all that oral cavity out, use the Yankauer suction, get deep, into the hypopharynx. You want to pack the surgical site so you're not getting more fluid going down in those areas. You want to position mandible forward, listening for a crowing sound. You can also see their chest kind of goes through this like rocking motion. You know, their abdomen is trying to work, and you can tell their chest, and they go through this like rocking situation with breathing, and so you can tell that they're struggling, they're obstructed. Listening for that croning sound, that's a telltale sign that that we have a laryngospasm going on. Give that positive pressure O2. If the laryngospasm doesn't break, then you can administer 20 milligrams of succinylcholine. Now, this is obviously an IV situation, but that will help, you know, paralyze the muscles, break the spasm, and then you can breathe for them or intubate if necessary. Bronchospasm. In an awake patient, you want to administer 4 to 8 puffs of their beta agonist. So if they have their inhaler, their albuterol, you know, get them some puffs in there. You know, try to break that bronchospasm. Administer supplemental oxygen via a face mask. In an obtunded or non-intubated patient, you know, consider using the albuterol nebulizer through the face mask. And you know, prior to the administration of epinephrine, which is another possibility to you know, administer 0.3 to 0.5 milligram of epinephrine. That's in 1 to 1,000 situ solution subcutaneously. If hypotension is still present or is present, then you can consider that a sign of anaphylaxis. Hypoxemia in spontaneously breathing patient, you want to administer oxygen by face mask. Consider reversing the sedative medication. So we go back into our preparation. Do we have Narcan on hand? Do we have flumazenil on hand? You know, if we've combined an opioid or we used an opioid for the sedation, then you have Narcan on hand. If you use a benzodiazepine, then you have flumazenil on hand. Perform chest auscultation, so listen, see, you know, what's going on. Are they breathing? You know, can you hear the air passing? If you need to, then you can intubate and then administer positive pressure ventilation with 100% oxygen. If the patient continues to deteriorate with hypoxemia, then you have, you know, impending respiratory muscle exhaustion or worsening obtundation. So these are 911 scenarios. How to handle emesis and aspiration. Put the patient in the Trendelenburg position, head down. You don't want any of this, or you try to create some dependent drainage of the aspirate, you know, so it's not sitting in the lungs, and you know, have them roll on their right side. So if we remember from anatomy, the left lung takes the bronchi take right angle turn, and so if we're rolling them on the right side, we're getting some of that dependent drainage come out of that left lung down into the trachea or the bronchial tree, and then if they're in Trendelenburg, then it will drain more towards the esophagus and oral cavity. So clear any of that vomitus and in the oropharynx with finger sweeps or large bore suction. If no improvement, put the patient in a supine position, intubate, that may be necessary, and you may have to use muscle relaxants prior to intubation. Remove any solid particles in the laryngeal region with the McGill forceps. Oxygenate the patient as soon as possible. Try to manage any bronchospasm, you know, with albuterol, as previously described. Tracheobronchial lavage is not performed except in small volumes, so 5 to 10 millimeters of saline to facilitate suction. And maintain patent airway and continue ventilation with 100% oxygen en route to the hospital. Cardiovascular emergencies, you have angina and acute myocardial infarction. You want to terminate the surgery and all stimulation of the patient. You want to place the patient in a comfortable position, loosen tight clothing, Oxygen, so we're going through this, the acronym MONA, right? Which is morphine, oxygen, nitroglycerin, and aspirin, not necessarily in that order. Okay, but you know, the MONA kind of gives you the idea on what is going to be happening. But first, oxygen. You know, want to make sure we have a good idea of what their oxygen levels are with the pulse oximeter. If you have an EKG, if you're doing IV, then you should have an EKG. You want to obtain vital signs, automatic and standard blood pressure or cuff. Administer nitroglycerin sublingually. If you have spray, you have tablets, you know, sublingual tabs. You can do that every 5 minutes. Check your blood pressure. Make sure that the systolic blood pressure is over 90, so you're not going to have a hypotensive situation. And establish IV access if you already don't have it. If the acute myocardial infarction is suspected, then activate the emergency medical system. So, you know, dial 911. Okay. Employ the mnemonic MONA. We talked about that, not in that order. ONAM, I guess, is another way you could say it. Chewed aspirin may decrease absorption of subsequent nitroglycerin. So the administration of non-enteric aspirin, 160 to 325, and direct the patient to chew one and swallow one, except in cases of allergy to the drug. Morphine, if you have morphine, you know, 1 to 3 milligrams IV every 5 minutes to control pain. So the systolic blood pressure is greater than 90 millimeters of mercury. You know, we don't want to drop their blood pressure once again and get them in a hypotensive situation. So watch carefully so the patient doesn't become overly sedated or lose respiratory drive with the morphine as well. Monitor vital signs, watch for hypotension, hypoxemia, bradycardia, ventricular dysrhythmias, cardiac arrest. You know, make sure you're ready to go for ACLS protocols. Okay. So neurocardiogenic syncope or vasovagal syncope, you want to place the patient in reclined position, legs elevated. So put them in Trendelenburg, maintain the airway, deliver oxygen, support breathing if needed, take their vital signs, apply a cool rag to their forehead, administer. You can't, if you need to wake them up, you can, you know, break your ammonia tablets, get them awake. If they need a little help in increasing heart rate, then you can give them some atropine, and that's 0.5 milligrams every 3 to 5 minutes, up to 3 milligrams in the presence of bradycardia. Hyperventilation syndrome, you might see this every once in a while. We see this every once in a while in recovery, but you want to maintain adequate oxygenation levels while reducing carbon dioxide elimination. So using an oxygen delivery system with a full face mask and a closed circuit with no carbon dioxide absorber, that you can deliver oxygen at 600 milliliters per minute. If you have the patient breathe into the circuit until the rebreathing bag is distended. Repeat that episode until it subsides. If using the anesthesia reservoir or a paper bag, you can have them breathe into a paper bag, and that can help. You know, at 6 to 10 times per minute. That's normal breathing. So if you can get them, you know, to be compliant with that, it will help. Seizures, you want to just try to protect the patient as much as possible so they don't get hurt. Loosen clothing around the neck, place a pillow under their head. If you have a bite block, you know, put a bite block in there. Just make sure that you're not going to swallow it. So, you know, you have some floss threaded through the bite block, or you have a tongue blade or side action mouth prop, whatever you need, just so the patient's not biting their tongue. Consider checking their blood sugars. Okay. If the local anesthetic overdose is suspected. Okay. Put the patient in a supine position, administer oxygen, maintain airway, transfer to the hospital if needed. If they need you know, they're going to have this latent period after their seizure. So it may be a situation depending on how they handle seizures. You know, they may need a trip to the hospital. Diazepam or benzodiazepine are great for the treatment of convulsions. And so if you have that ability, most of the time you're using those medications for your sedation anyway, but if they need another little dose, that might be something that you can do. Allergic reactions, you know, mild reactions usually manifest in skin reaction without other systemic signs or symptoms. So identify the causing agent. If time permits, remove it, dilute it, negate it, antagonize it if possible. You want to administer Benadryl, so 25 to 50 milligrams PO, 10 to 50 milligrams IV at a rate generally not exceeding 25 milligrams per minute. Or you can do a deep intramuscular injection of 100 milligrams if required. Maximum daily dose of Benadryl, 400 milligrams. A severe reaction or anaphylaxis. This is manifest with all signs of allergic reaction: skin rash, watery eyes, abdominal cramps, wheezing, tachycardia, and hypotension. I was involved in a anaphylaxis situation when I was on anesthesia as a resident, and it's kind of hard to tell in an operating room setting, to be honest with you, because you're giving antibiotics and you're giving several medications to get them off to sleep and steroid and everything else. But I remember, masking her and it being so, it started off easy to mask her, and then all of a sudden it got really difficult to mask, and I wasn't able to pass air. And luckily, my attending doctor was there, and he took over, and he recognized that her airway was extremely swollen at that point, and was able to get kind of a blind intubation and saved her life. Was able to get her on steroids and Benadryl, and she ended up doing fine. But this is one of those situations you just don't know who is allergic to what, and they may not have ever had a history of allergic reaction. They may not have ever been exposed to some of these medications that they're getting. So, always having that in your mind that that's always a potential is important. So, have a plan or algorithm to guide your treatment in these severe allergic reactions, impending cardiovascular collapse. Now, luckily, with this lady that I talked about, she didn't have any huge fluctuation. And, we were able to intubate her fast enough that she didn't, crash, have a cardiovascular accident or emergency. But that is a possibility, if they lose oxygen for long enough. So you want to stop the administration of the antigen, follow the ABCs, support the respiration, breathing, support the circulation. Get an IV going, get some fluids going. If you need to, support as much as you can by getting fluids in their system, steroids as soon as possible, or Benadryl, some antihistamines. Epinephrine, if you have epinephrine, is extremely important. 1 milligram of epinephrine in a 10 milliliter solution is going to be probably the best treatment for an anaphylaxis situation. If you need to titrate 0.2 to 0.5 milligrams to affect, repeat that every 2 to 5 minutes as needed. And children is 0.01 milligrams per kilogram. If you're going intramuscular or subcutaneous, it's 0.3 to 0.5 milligrams subcutaneously to help. So your EpiPen doses in anaphylaxis situations. And that can be repeated every 10 to 20 minutes if needed. Children, the 0.01 milligram per kilogram, that can be repeated also every 10 to 20 minutes. As epinephrine administration continues, the antihistamine can be administered either IM or IV. The diphenhydramine or Benadryl, that can be given at 50 milligrams. You don't ever want to start at 25 and see how it goes, and then give another 25. just start with the the maximum dose, 50 milligrams. The children 6 to 12, you probably want to start at 25 milligrams. You can give H2 blocker, Pepsid, can be given, and that's 25 milligrams or 20 milligrams rather. And children dose on that is 0.5 milligrams per kilogram. And then albuterol inhaler can be administered as well, 4 to 5 puffs as needed. So getting some steroid in their system can help as a good anti-inflammatory. So corticosteroids, once again, we use in the office Decadron. We give Decadron for different reasons, not necessarily allergic reaction, but to help with swelling. So it's a good anti-inflammatory. But that's part of our normal dosage for our normal sedations. But if you're not giving Decadron, the use of corticosteroids has been advocated for these types of situations. Hydrocortisone, 100 milligrams for 1 minute is going to be your best situation. And once again, I mentioned Decadron. We use that dose of 4 to 12 milligrams given slowly, either IV or IM. That can be repeated, if needed in an anaphylaxis situation. So if you do end up having an adverse event in your office, we determined in 2018 is going to be important to report this to DOPL. So if you have a situation where you're escalating the care to, and usually in a dental situation where you're escalating care, you're calling the paramedics, you're sending the patient to the hospital, this event needs to be reported to the hospital, or excuse me, to DOPL. We just want to have a good idea on what adverse events are happening and how we can better serve the community and make sure that people are going through the best care. So this is a requirement of reporting the adverse events. So hopefully we don't ever have to do this, but we need to be prepared, and we need to be prepared for situations, emergencies, and they happen. So don't feel like this is something that you've done or this is your fault or whatever. It's just something that's going to help, that we can better track these situations from a statewide perspective and better protect and serve our community. If you want to find out, this is section 26.140 on the whistleblower protections, reports of anesthesia adverse event. So if you want to go through all that, totally fine. I know it's a lot to kind of go through in this lecture, but a lot of small type and things. But anyway, that's it. I hope it was beneficial. I know there's a lot of boring stuff in terms of pharmacology and things, but it gives you some ideas on things that you can use and some armamentarium for oral sedations in your office, things to be aware of, things to be prepared for. I know it's been a huge blessing to have the ability to sedate patients in my practice. More and more people these days want to be sedated for their procedures. They have anxieties towards a lot of things in life, and dentists happen to be one of them. So if we have the ability to help them overcome those fears, then let's do it. Let's do it. But let's do it safely. Let's make sure that we have the ability to look out for our patient and give them the best treatment possible. Anyway, I know you guys are out there doing great things, and I appreciate your attention. Thanks.